Glad to have you all here. We've got a really great group of speakers who are real leaders in the field, and we really appreciate their time and participation. And I think you'll learn a lot from them. This is definitely an A-list of folks, and also a great group of graduate students and postdocs who are going to help out with all the various teams, and we really appreciate their effort as well. And again, these are the people who are leading the work, and as anybody in academia knows, it's the grad students, the postdocs who do the work, and so we really appreciate their efforts. Particularly, I want to say this conference was led and designed almost entirely by students and postdocs, and I want to particularly thank by name Kevin Ma and Tiggy Menkir and MIDAS-CCDD, who will be on, and you'll be seeing and talking with them. They've just been fantastic about putting this together. I also want to thank Jessica Kerr, one of my team members at Pittsburgh, who's really putting valuable effort into this, and we really appreciate all the help with that. So thanks again for coming. I want you all to enjoy, have fun, learn a lot, and make some friends. And I'm going to pass the baton to Yonatan Grad, who will just introduce himself and his work at Harvard.
Thanks, Harry. Just a great introduction to the conference, and I'd like to echo those words as well. So on behalf of my colleagues here at the Center for Communicable Disease Dynamics at Harvard, I'm totally delighted to welcome you to this conference. So the CCDD is led by Mark Lipsich, who I believe you'll hear from later on in this conference. He's now 80% time at the CDC, where he is founding co-director of the Center for Epidemic Forecasting and Outbreak Analytics, a new center there, applying many of the things that you will learn about over the course of this conference to, as we have learned, that desperate needs in society for application of infectious disease dynamics and modeling and epidemiology. I think this is, it looks like it's going to be an amazing conference, fun, educational, and inspiring. And we'll give you a sense of the kind of work that we do and its application broadly. So with that, I'd like to join my voice to the chorus of thanking Tiggy, Madike, Kevin, and Jess, and all of those who have put hard work into organizing this conference and an exciting program that will take place over the next couple of days. And as well, thank all of you who are participating, and I hope that this will be a fun, worthwhile, and exciting time. So with that, I will turn it over to Tiggy.
Thanks, Yonatan and Harry. Hi, everyone. I just want to say welcome. We are so thrilled to have you join us for this conference. My name is Tagus Torti, and I'm a PhD student in infectious disease epidemiology at the Harvard CCDD. And I'm speaking on behalf of the MIDAS-CCDD Outreach Conference organizing team, who they've already introduced, but I'm just going to do a deeper dive into introductions. We have Jess Kerr, who has led all of the wonderful intro to our workshops and has been communicating with you all. And she is a PhD student in epidemiology at the University of Pittsburgh and a project coordinator for MIDAS. We have Dr. Madike Sankor, who will be giving the first lecture on Intro to SIR Modeling, and he is a postdoc at the Harvard CCDD. And then we have Kevin Ma, soon to be Dr. Ma, who will be a juror for the project presentations, and he is a PhD student in biological sciences and public health, also at Harvard. So to start off, I just want to reinforce Harry and Yonatan's message on why expanding participation in research development, practice, and communication is so critical in our field. As we've seen very clearly during this pandemic, there are appalling inequities in who is most severely affected by disease, death, and the many social, environmental, and economic risks and consequences of infection. And the challenge is that sometimes the mathematical models do not see or fail to effectively account for these disparities, and thus they can't directly inform strategies which may target them. So this is one of the many reasons why we need more diverse researchers. to expand the scope of the kinds of questions we are willing to consider in our research, and to normalize centering a range of experiences in our quantitative frameworks. And so for this to happen, we need a kind of grassroots modeling initiative where students such as yourselves, community members, and partners can all work to contribute to research in academia. So grassroots modelers can identify most pressing needs for a given community, the diverse data sources that can be useful for addressing these issues, and shape how the research is ultimately conducted. We just want to stress that mathematical models are made more accurate, informative, and broadly useful for everybody by integrating these diverse perspectives and experiences. So I'm excited for the prospect of us all participating in a more diverse and inclusive modeling grassroots movement. Okay, so now on to logistics. As you all know, the conference will be a mix of lectures, breakout sessions, research talks, a career panel, and project groups. Most of the breakout sessions will be a large group activity, but for the first session where you'll be putting to practice some of the concepts that Marike will introduce in his lecture, you will be split into 2 groups based on your prior programming experience in R. We really encourage everyone to participate and speak up during the sessions, particularly the interactive breakout sessions. We'd love to hear from and learn from you during these discussions. You will also have the opportunity to meet with your project groups on all 3 days. And so just to introduce what this is, the project groups are basically a forum for you to work with your fellow participant under the mentorship of a MIDAS-CCDD student or postdoc to apply some of the methods you will learn throughout the conference to develop a modeling proposal to target a specific question. You've been assigned, each of you will be assigned a general thematic area, but you can select a question within this that you're most passionate to address. And then on Sunday, you'll present a brief proposal with your paired participant, and we'll have a panel of jurors, of which one of them is Kevin, and they will use a project rubric which you'll be introduced to later to select a winning group. Okay, so that's all in terms of an introduction to the conference. I will pass it back to Harry for an introduction to our first speaker, our keynote speaker.
Excellent. Thanks, Tiggy. So we are really pleased to welcome Jon Zelner to give the kickoff keynote for this conference. And I want to say that Jon was, like so much of the rest of this, was selected by the student organizing team. I only had to do the very easy work of sending a quick email, which with Jon was gracious enough to respond to in almost, I think, less than an hour. So it was great to get that response. But Jon is an assistant professor in Department of Epidemiology and a Center for Social Epidemiology and Population Health at the University of Michigan Public Health, where his research focuses on the intersection of biological mechanisms and social mechanisms, how they generate spatial variation and social inequity in patterns of infectious disease transmission. And this is one of the things here that I think if we look at the news reports and we see how the impact of COVID has been so different across different groups, the relevance here is really obvious. And it's a really, really timely and important set of problems. But that's not all that Jon's done. He's worked on a broad range of infections, including tuberculosis and influenza, as well COVID and other vaccine preventable diseases and diarrheal disease. So I think Jon is going to give us a little bit of talk and a little bit of a demo, if I'm not mistaken, of some of his systems. And I know I'm really interested in hearing this talk. So Jon, the floor is yours. Thank you so much for joining us.
Yeah, thanks, Harry. Thanks for the introduction. Thanks to everybody for having me and for organizing this great meeting. I did make a little bit of a left turn in terms of what I'm going to present today. So we might not do the demo, but I will send the link around for that for anybody who's interested in it for after the fact. So hopefully you guys can see my screen at this point. And I will keep my eye on the chat, but also feel free to like pipe up and ask any questions. If you see me looking off to the side, it's because I have you guys on one screen and the presentation on the other. So, the title of the talk is there are no equal opportunity infectors. And this is the title of the paper we have coming out that Ramya Narahari, who's also a member of my group, who's joined us this morning, is an author on as well. Okay, so my goals for today in doing this talk are the following. The first thing I want to do is to talk about why epidemiological models and modelers, right, and the role of the modeler here really can't be overstated, have ignored inequality in our approach to pandemic preparedness in particular. And then I want to suggest an alternate path that builds on the many strengths and successes of modeling during the COVID-19 response, right? So, I mean, there's some things here that are kind of critiques or kind of thoughts about how things can and should have been better. And I want to make sure that everybody understands when I make those critiques, I'm placing myself under the roof of the people who are worthy of kind of criticism or second thoughts, right? I think we were clearly not prepared, particularly for the scale of the inequalities in the pandemic. And I think there's some serious structural reasons for it, which kind of get at the why this conference is meaningful and exciting. And finally, I want to highlight why making new models that reflect this diversity of understandings about how these transmission systems work, right? The mechanisms that underlie these models are, we often think of them as kind of abstract and as like there being an absolutely true representation of them. But I think what we've seen and what I think we increasingly understand is that there are many ways of doing this, and the ways that we approach it really reflect where we're coming from. Okay. So clearly models and modelers have been key to the COVID-19 response. This is a piece from March of 2020 that was in Science. And I'll just let you know, there's links to all of the things that are in these slides and I think Jess may have sent the link around. If not, we can send it later if you want to follow up with this. But this is from the very beginning of the pandemic. And here's this news item saying that with COVID-19, modeling is taking on a life and death importance, right? Which for those of us who've been in this field for a long time, it was not surprising to see that models were going to be kind of at the forefront of the response. But at the same time, it was really the first time where we were kind of pushed out there right at the very beginning and sort of at the tip of the response. And so this is from the WHO's website. And basically, I think it's important to kind of highlight how modeling has become this like very important part of pandemic preparedness. And I just want to talk about what it means to be prepared for a pandemic, right? And it's essentially this continuous process of planning, exercising, and revising our plans, right? And so what we're prepared for are the things that we've been thinking about ahead of time. And some of that is very formal in the sense of coming up with like a plan that we're going to use when an emergency strikes. And part of it is more about the kind of ecosystem of ideas that we live in, right? And I think when the COVID-19 pandemic hit, we found ourselves both lacking in terms of the formal preparedness for domestic and global inequality in infection risks and in mortality risks. And obviously, we also found ourselves kind of lacking the appropriate modeling frameworks to encounter this inequality in a productive way. Okay. So, I know that you guys have probably have varying levels of exposure to epidemiological modeling. And I want to talk about kind of, from my perspective, why these models are so powerful, right? Clearly we talk about mathematical models in a kind of formal scientific way, but in my experience, and I've been doing this sometimes it surprises me, I've been doing this for a while. I started grad school in 2006. So it's been a number of years. And one of the strongest reasons to use these models is because they shape our intuition, right? And I love this quote from Daniel Dennett, the philosopher, who describes intuition pumps as a kind of thought experiment where we focus the reader's attention on important features and we kind of push the things we think are not important off to the side, right? And these transmission models, from what we've seen in what's been shared in the media and what's kind of been at the top of the scientific conversation, it's very clear that what's in the model shapes the conversation, right? It shapes the public health conversation, it shapes the political conversation. And so they're very much of this variety where what we put in here is implicitly what we're saying is important, right? And I want to kind of unpack why the things that are in these things got there and, how we might think about sort of retooling things a little bit. So, what do we do with these models, right? They're powerful because we can use them to characterize things like rates of transmission. So you may have heard of the transmission parameter R naught, which is the kind of key value in a lot of models where we're thinking about the overall rate of transmission, right? There are other parameters that really matter, right? Like what fraction of people are going to develop severe disease, who's going to die, right? What are the individual and demographic risk factors that are associated with that? They can let us think about the impact of medical interventions on risk. So this might be, most notably in the recent past, vaccination, but non-pharmaceutical interventions like masking and social distancing as well. And I think we kind of undercount the ability of these as tools for thinking about the implications of social and political change and action on infection risks, right? So we tend, our focus as modelers, I think, is often kind of at the level of national, international, or local policies. And we're kind of coming at it from the perspective of a policymaker, right? And I think that might reflect might explain some of the blind spots that we've had about, what goes into models and what stays out of them. Okay. So I want to take us back around March 2020 and just kind of think about what those early pandemic models were really focusing in on. So big focus on age-specific incidence of COVID-19 and mortality, right? Obviously, this is something we cared about, and should still care about quite a lot. One of the things that we saw right at the beginning was huge amounts of mortality among older people. If you'll remember, there were these waves of infection in nursing homes and long-term care facilities, right? And so age is a really important part of certainly the COVID-19 story, but I think there's not an infectious disease system where age is not important for any number of reasons. Sometimes it's a biological reason, sometimes that's about who contacts whom, right? Age is a kind of central dimension of variation that we focus on over and over again for good reason. We were prepared to think about hospital and ICU capacity, right? So we wanted to make sure, if you remember the phrase flatten the curve, which feels like it comes from a kind of bygone, simpler era where we thought we could maybe kind of slow this train down. Part of the idea behind flattening the curve at the beginning of the pandemic was to make sure that hospitals and intensive care units weren't overwhelmed beyond what they could handle. There's also been a lot of work doing short-term forecasting of incidence, so the rate of new disease and mortality from infection at the population level, right? And so obviously this kind of short-term forecasting is important if it's done well for kind of helping us think about what might be coming next, and again, preparing for the next thing. And then there were obviously focuses of things like policies like lockdowns, right? And so when we take on some big kind of costly, and I mean costly both in the financial sense, but just in terms of people's energy and time, like a lockdown, we wanted to have some confidence that it's actually going to do something, right? And so certainly models were a key part of saying, what happens if we shut down schools? A lot of models focused on that. What happens if we close down workplaces? What happens if we restrict travel between parts of a state or between states, right? And all these things. And, we would hope to see something like this on the list, right? Who is getting infected, right? So we've got all these kind of dimensions here. We're looking at age-specific variation. We're thinking about who's ending up in the hospital, what might be happening over the short and long term. And it would make sense to say, well, and then if we break the population down by the kind of classic cleavages of socioeconomic status and race and geography, which kind of often reflects both of those things, that, that's going to be an important thing that we should be thinking about. I don't think that that is a radical statement, but it really wasn't part of the picture circa March of 2020. And I wish I could say that, in February of 2020, when we saw this kind of COVID train sort of coming over the hill, that I was one of the people who was sort of standing there and saying, we have to think about this, right? We have to think about who's going to get infected and how that reflects existing inequalities. And I probably had it in the back of my head that that was an important thing, but I'd fallen into the same trap that I think a lot of us had about what was going to happen. And that is this myth of the equal opportunity infector. So I'll spend a couple of minutes. I just want to talk briefly just about the inequality being a central part of the story, and then we'll talk about what it means to be an equal opportunity infector and why that's such a powerful kind of myth. So obviously we know that inequality is a central story of the pandemic. At the beginning, the big questions in the US were being asked about why African Americans were dying at higher rates from COVID-19 than whites in particular. A lot of the speculation here focused on ideas about comorbidities and people having greater sort of health liabilities, and that making it more likely that Blacks would die from COVID exposure than same-aged whites, right? And we actually did some research that Rania is a part of as well and is doing some follow-up work on right now that shows that it had not very much at all to do with differential rates of mortality by age, and a lot to do with exposure differences, which were likely related to essential work and people living in crowded or difficult housing conditions, right? The things that we think of as being associated with social inequality, right? Like, were what was really driving this variation in outcomes. But we have this kind of preconceived mental model about the health of different groups and its implications for mortality from this infection, even though this was an infection, we'd only known about for like a couple of weeks at this point. And so, these are just kind of other examples, of the way that inequality was coming up, both in the US, this is an example from the UK as well. This was an early key story of the pandemic, and it remains one right now. When we look at the Omicron surge, we're kind of seeing the same patterns of inequality play out again. Okay. So this myth of an equal opportunity infector and like pandemic pathogens like SARS-CoV-2, like pandemic influenzas being these equal opportunity infectors, may have been something that really obscured or kind of crowded out our anticipation and preparedness for this inequity, at least from a modeling perspective. So this is from an early paper saying that COVID-19 is a new equal opportunity virus, right? And it's saying that it's much more infectious than previous influenza pandemics. And it can be transmitted quickly and before people develop symptoms. And so all these biological features of this pathogen make it this equal opportunity infection. It's just going to blow through the population and it doesn't care who you are. And then this is, a relatively recent article that kind of throws a little bit of a political spin on it, just sort of saying Omicron's an equal opportunity infector. Look, like AOC and Elizabeth Warren and Cory Booker, who are all Democrats, have tested positive, which is kind of a silly distinction, but there we go. In rural contexts, originally people were thinking that this was something that was primarily a problem of cities. And so people were saying this is an equal opportunity infection. If you live, in the country, you can get infected, which of course is true, right? But like this term equal opportunity infector has been kind of floating around, and it's been around for quite a long time. Similarly, when every time we get a new variant, this kind of pops up again. Okay. So, what does it mean to be an equal opportunity infector? So if we really want to think about this from like a transmission dynamics perspective, right, we'd have to assume that everybody is uniformly susceptible across the entire population, so that anybody who's exposed, regardless of kind of their social or health background, is equally likely to get infected. So this obviously is a shaky assumption. And then when we think about infectiousness, we're saying that host, so our individual biology and the biology of the pathogen, this new virus that nobody in the population has seen, are the most important factors in determining infectiousness, right? And that's not necessarily saying that there's not variability in rates of contact and things like that, but that if you have something that's so infectious, right, like particularly like Omicron, but also like the wild type variant, the original pathogen underlying the pandemic, it's all of that just swamps all this social variation. And then things like protective health behaviors would have to kind of be equally available to everyone. So the ability to social distance, the ability to work from home, would have to be either not effective in protecting you, so that it's like if you go to the supermarket for 5 minutes in April of 2020, or you're working in a Starbucks, you're at equal risk, then, that would have to be true again for this to be an equal opportunity infector. And finally, these social differences in exposure by race and wealth and other factors are dwarfed by all these biological factors. Okay, so this is kind of a laundry list of like shaky assumptions. And certainly, as somebody who's like considers themselves to be a social epidemiologist, my training is in sociology as well as epidemiology. My focus is in many ways on inequality and infection. I kind of bought into this model, right? Because I thought this is so infectious. It's not that inequality doesn't matter. There's going to be inequity in certain outcomes, but ultimately, like, this is a train that's just blowing through, and we're like all going to get it. And we're all going to get it at the same time, and we're all going to experience, kind of similar issues. So, one thing that's really important to remember is that we don't really have to believe that all of these things are true for them to end up in our models, right? So when we create a mathematical model, sometimes that thing can look like very authoritative, right? It can look like this kind of, the equations are written out, and it's kind of this like scientific object, right? But it really is just a reflection of the kind of mental models that we're bringing to the table. And you don't necessarily need to think that all of these things are true in order for them to end up in your models. You just have to kind of be kind of going with the flow of the ideas that are out there, if that makes sense. And please, if you have questions or thoughts, don't hesitate to interrupt. Okay. So, we really have to understand the mental models that are guiding the construction and analysis of the mathematical ones if we're going to figure out how to fix them. And so this is a nice quote from a recent paper by Tricia Greenhalgh, who's a philosopher, and she talks about the role of mental models in the COVID-19 response, and particularly with respect to the transmission modeling community. And so she says that mental models and data keep each other in check. And this philosopher, Peter Medawar, described them as the bride and groom of science. This is kind of a dated reference, but you kind of get the idea, right? That scientific progress really depends on a kind of dialogue between our mental models or mathematical models and the data, right? The data we collect are kind of constrained by the models that we're kind of using to say what's important. And of course, the data that are available limit the scope of problems that we're going to be able to address with our models. Okay. So I'm just going to, the door popped open here. I'm just going to close it so you don't hear my son walking around. So let's dissect the mental model behind the equal opportunity infector idea a little bit more. So I just want to ask a couple of questions, right? In thinking about this dialogue between models and data, what types of data do the models, particularly the early pandemic ones, the ones where we weren't quite prepared for what happened, what kind of data do these models use? Who's typically been in the audience for epidemiological models, and is that changing at all? And what is it that we could do to expand the toolkit to really dig in and be ready for these critical questions of inequity? Okay. So, who are epidemiological models for? And this is a question I'd like to ask you guys, and certainly feel free to unmute, or if you just want to pop it in the chat, that's also totally fine. But when you think about the audience, like who are the, particularly if you think about like March, April, June 2020, when we're getting kind of predictions of models from different research groups and different organizations in the press and in, you know, from the government, you know, who is that information really aimed at?
Maybe the policymakers who were responsible for keeping people safe, or employers or people like, you know, responsible for the school system, letting kids go back to school.
Right. So I think that's exactly, so policymakers, employers, right? Folks who are kind of responsible for setting the rules, setting policy, and kind of saying what's, you know, what's safe to do, what's not, what's, you know, what's a trade-off that we can make sort of economically and socially versus one that we're not willing to make it in the name of public health. Any other, you know, audiences or consumers of these things?
I think also anyone in a position, like anyone in like a public health task force who would need to be in control of the safety of many people, say a community, would also need to look at epidemiological models as well.
Right. No, absolutely. Right. So you have, you know, state and local public health authorities are looking at the models that were coming out of the CDC, that were coming out of different research groups at the very beginning of this, and saying, well, here's what we think might be happening, and we're going to kind of prepare for that, right? Or these models say something about what social distancing, mask wearing, school closure can do, and we're going to kind of focus in on those things based on those recommendations. Any other thoughts about, you know, potential audiences or you know, people who are influenced by these?
Maybe doctors, so they could know what's going on and how to, like, how you say it, slow down the spread in their patients.
Totally, yeah. So physicians, I think, end up being a really important component of this. I think if you're a doctor, you're working in the emergency room, or you're a critical care doctor, critical care nurse, you're thinking, you know, you're probably, and your hospital is probably thinking about, well, this is what the projection is, and so here's how many patients we should expect, and maybe we should stop doing surgeries, right? So there's kind of a policy angle to it, and then there's the other part that says, when patients come in, you know, how do you talk to them about their risk? How do you explain to them the risk environment that they're in, right? So I think these are all like really excellent examples that, you know, kind of get at sort of this similar ones that I was thinking about, right? So scientists and physicians who are pursuing some kind of intervention, public health officials who are making some kind of decision, politicians who are implementing policies. And I think the other part of this that's very important is that they're also trying to, you know, build and maintain political power. And that's something that we should be thinking about when we think about public health recommendations. I think another part of the equation here is the media, who are trying to construct a narrative that people can kind of understand, right? And that kind of moves towards simplicity, that moves towards, you know, a couple of talking points that everybody can get their head around. And of course, again, you know, there's only so much any of us can fit in our brains. Like, simplicity is not a bad thing. Let me go back to that idea of the intuition pump. It's, again, what do you choose to put in the picture and what's out, right? And clearly, you know, age-specific mortality was in, you know, social and racial inequality was in later on, but the mechanisms were not, right? The things that might be generating that were completely absent from the picture. And so to me, the thing that these groups all have in common is a kind of perspective of power, right? They're coming from, you know, a position to either make policy to impact individual people's health, or to, you know, shape the way we all think about this, our common understanding, right? And often epidemiologic models are pitched towards that position of power. And I think that's obviously a deficit in what's gone on in the early days of the pandemic. And we've seen the results of that kind of trickling out as we go along. So, you know, this has led to focus on a set of outcomes that align with these interests. So again, the incidence of disease over time, the prevalence of infection. So, you know, how many people are infectious at any moment, such that we can calculate how many people we might expect to get infected tomorrow, mortality and case fatality rates, distributions of infection and mortality by age. And ideally, we would like to see the distribution of infection and mortality by socioeconomic status and race and ethnicity, but we weren't really there. Okay. So I'm mindful of the time because I know we're getting relatively close and I want to make sure there's time for any questions. But I just want to highlight the fact that, our modeling of acute infections like influenza, like SARS-CoV-2 has really come from this rich tradition in population ecology. So we have these key model parameters like R0, which describe average properties of infection in a well-mixed population where everybody is contacting each other roughly at the same rate. And obviously this is not a faithful representation of what happens in, our society, but, it does work quite well for a lot of cases and for a lot of outcomes, right? So if you're focused on those high level kind of aggregate outcomes, you can get away with some pretty simple models. Our key ideas are really borrowed from classic models of predator-prey dynamics and birth and death processes in ecology. And because of that, ecological modeling and epidemiological modeling by extension has a huge toolkit for thinking about demographic, like that age-specific variation I talked about at the beginning, as well as spatial variation and outcomes. So the tools are all there to do a better job, right? It's really a question of how we, kind of think about how we brick them together. And of course, we've been slow to make that leap. Okay. But this was incredibly obvious, right? So I think that's the flip side. So no more excuses like, how do we screw this up, right? How do we miss the fact that justice is this critical dimension of pandemic preparedness, right? And I use this GIF, which may date me a little bit, of Charlie Brown, missing the football, because I think it just kind of underscores the feeling of a certain kind of failure that we should all kind of digest and try and come to grips with. So historical analyses have repeatedly demonstrated inequality in prior pandemics. This is from a great paper by Kyra Grants, as well as other folks at Florida at the time, who really looked at inequality in influenza mortality during the 1918 flu pandemic in Chicago, right? So they dove in and they saw many of the same things that we saw in 2020, 2021, and 2022, right? So the framework was there. It's not like people hadn't been thinking about this. And then among social epidemiologists, social scientists, the mechanisms of inequality. So here, when we think about, occupational exploitation, particularly of non-whites, African-Americans, people of lower socioeconomic status, right? People were aware of this from the get-go, right? This was published in July of 2020. People were probably writing it in March of 2020, right? Like people got it, right? And anybody who could have their eyes open would see that this is what was going on. And, there was some great work by a social epidemiologist named David Williams, focused on the idea of rethinking some of the core ideas that undergird our models. So this is from a paper about the idea that the US has to develop a different conceptualization of herd immunity, right? And this idea of herd immunity is one that was talked about a ton at the beginning of the pandemic, less so now as we've kind of learned what that means or doesn't mean for a pathogen like SARS-CoV-2. But the Williams interpretation of herd immunity doesn't just get at, how many people have been infected or vaccinated. It gets at what are the factors that are conditioning people's susceptibility to infection and poor outcomes, and how do we kind of push those strengths, right? Push strengths, either address these kind of weaknesses, but also capitalize on the strengths that communities have to, protect themselves, right? So it's a much more expansive vision of what we can and should be doing. So, what could an alternative modeling framework look like? And this comes from the paper, which has the same title as this talk, that should be out pretty soon. But if you're interested in the preprint, you can find it at that link. It could look like epidemiological models that model proximal infection risk. So your exposure, your risk of infection upon exposure as a function of upstream social determinants like racism, like socioeconomic status, like residential segregation, like differential access to medical care, and so forth. And then kind of connect that to all the different phases of infection, right? Because we know that your outcomes aren't just about what happens when you're exposed, they're about what happens when you develop illness, when you go to the doctor, and so on and so forth. They could represent the correlation between the effects of factors like racism and socioeconomic status, right? We know that these things don't come one by one. We have a tendency to kind of treat them as separate phenomena. And again, there's sophisticated ways of thinking about this from the social science literature, and I think in ways that a lot of us intuitively understand, but that's not in the models that we use right now. And finally, they can let us examine the differential impacts of inequalities on rates of contact, susceptibility, and infectiousness, right? So both the biological stuff that's under the skin and also just the social things that kind of, drive all these different patterns. So the good news is that, this shift is already well underway. I didn't pick this as an example just because some of the folks are here, but I think the fact that we're in a conference that's organized by these folks kind of speaks to the important work that they're doing in their orientation. So this is a great paper that came out in eLife, led by Kevin, talking about the impact of racial and ethnic disparities on the population dynamics of infection for COVID-19. It's a great paper. And these kinds of equity-oriented models, this is another paper that recently came out in Nature Communications, can let us think about the causes of disparities and how concrete sort of policies like maintaining the CDC's eviction moratorium could prevent infection and death, right? And so we're kind of putting the mechanisms together. So I don't want to end on this note of pessimism because I think these changes are underway. And I think we're well on our way to being more prepared for these questions in the future and for addressing and ameliorating these inequalities, hopefully before they happen again, right? But it's obviously important for us to keep these lessons in the front of our minds or else we are doomed to kind of repeat this. So really the last thing I want to say is just to underscore that, at the head of this chain that goes from the modeler to the transmission modeler is the person who's doing the work, right? So perspective is everything here. I feel like I've been able to engage in some of this work both in my sort of social science background, the way that I think about the world, my interactions with students and postdocs and colleagues who have a broader understanding of the world. But clearly, the deficiencies of this framework that we've been kind of operating under reflect the environment in which these models have come up. So it matters critically who is developing the model, what the collaborative teams look like that are developing the model, right? This is not something that anybody does alone, and anybody who tells you that is not telling you the truth. You certainly won't be hearing that here. And our modeling needs to reflect this diversity in intellectual perspectives, as well as life experiences and economic and political interests. Great, so I'm gonna stop there. If you'd like to learn more about our work, please check out our lab website. We go by the name of the EpiBase group, and you can read more about why we call ourselves that on our website. Also, for anybody who's looking at graduate programs, certainly feel free to get in touch. I'd be happy to talk to you about programs at University of Michigan and anywhere else, and kind of what it means to pursue, an MPH or a PhD in epidemiology. So I will stop there, and I'm happy to answer any questions with the remaining time.
Great, thanks, John. A really interesting talk. Folks, if you have questions, please feel free to unmute or put something in the chat, whatever you like.
How do you think addressing the socioeconomic and racial perspective may have affected some of the earlier modeling in 2020? If you could shed any light on that, or if you have anything.
Sure.
Yeah.
So you're saying, like, let's say we could sort of rewind to March 2020 and have been thinking about these things concretely ahead of time, right? What might have looked different? I think that's a great question. So if we kind of go to here, right? I think things like, one of the things we saw right away at the beginning was this idea of essential work as being first this kind of like valorized category of workers, and then eventually became a way of forcing people of color and people with lower socioeconomic status into risky work environments by claiming they were so essential that they were kind of not protected by the kind of work from home and lockdown kinds of protections, right? So a model that kind of brought in not just the idea that if we have a lockdown, right, we will decrease risk, but that if we have a lockdown and we need to keep the economy going, and we have certain folks who are going to be more essential to that in one way or another, you know, how is that going to skew people's risk, right? Like, I think we could have started with just a broad awareness of that. I think another thing that I think would have been immediately apparent is the idea that it's not enough just to lock people down and to think about, you know, say like, we're going to stop everything and just hope that everything works out, because people don't have income, right? People don't have childcare. You know, there's all kinds of things that are going to prevent people from being able to do that effectively. And I think that that's one of the reasons we saw some of the very large early disparities, is that you have people of different socioeconomic means, some able to work from home, some not able to, some living in households with, you know, older parents and grandparents who couldn't help but be exposed to younger family members who are working in these essential work kind of context, right? And it would imply a set of policies that go beyond just telling people what to do, but also providing things like income support, right, to tide people over while they're out of work, or to keep their jobs so that when the period is over, they can go back to the position that they had, right? So I think, you know, if we think, then we can think about those things as essential, like public health interventions, right? We can think of them not only in terms of kind of their social qualities, which I think shouldn't really be up for debate anyway, but that's kind of my like political and kind of social perspective. But we could think about the fact that like every dollar you spend in giving people money to pay the utilities, to eat, and all of that is also worth like thousands of dollars in prevention, right? Like the amount of, in terms of, you know, years of life lost, the cost of healthcare and all these things, right? So to me, it's like, it's not to say that they would have changed the policies that are going on, because it does happen. We were happening in the context of what is and was a kind of brutal political environment that doesn't really sort of take into account people's humanity, and particularly the bodies of people of color, right? So like that wouldn't change necessarily, but at least the argument could come much more strongly that says like, you know, by refusing these policies, by refusing, you know, these interventions, you know, that are kind of social and economic in nature, you're contributing to people's death, right? And you're doing it in a way that it's easily preventable, and where the cost of doing it is way lower than the cost of not doing it, right? So at least it could force that conversation. Is that helpful?
Yes, thank you. It was very clear.
Great, thanks.
Okay, if nobody else has got any questions, I'll throw something out, John, that comes to mind that your points are all really great. I'm curious about when you talk about what modelers could or could not have done. I'm just wondering to what extent necessary data was or was not there, or is not there. And I know I haven't looked at this stuff since mid-2020, but at one point, at least then, it was really hard in many places to get county level information about COVID rates, let alone zip code level or something like that. So is the data really there to get into these fine-grained questions?
Yeah, it's a great question. I mean, and this is something that Rami has thought a lot about and has dealt with as well. So if you have thoughts, you know, certainly jump in. So, you know, we were lucky from the beginning to be able to work with the Michigan Department of Health and Human Services, who gave us access essentially to their entire case database, right? So that's kind of a best case scenario. We have every ascertained case, we have their home location, we should have race and ethnicity, we might have occupation, we have a lot of things that might be really helpful to us. So that's a best case scenario. So, and those data were not available in most contexts to most people. But within that, many cases are missing data on race and ethnicity, because as case rates go up it gets harder and harder for public health departments to keep up with that. And then add to the fact that the categories that are used are obviously imprecise. They don't account at all for kind of intersectional identities, but also they correspond to kind of like old, weird census definitions of race and ethnicity. And they're non-differentially missing, right? So different groups are gonna be more likely to be missing race and ethnicity, particularly depending on where you are and where you are in the epidemic, right? So even with those like kind of like best case data, we're like way behind. Then you throw on top of it the fact that race and ethnicity is not really like meaningful from a risk perspective, right? It's a reflection of a collection of social and economic factors. But what we really want to know is, what are people's resources? And there's been some work in terms of like social vulnerability indices and, metrics of area level income. But in an ideal world, we would know that more at an individual level, right? We wouldn't have to be kind of merging individuals with kind of area level data and potentially committing a kind of ecologic fallacy where we take a relatively diverse community from a socioeconomic perspective and we ascribe the characteristics of that whole community to every individual within it. Because we know, particularly among people of color, communities are considerably more socioeconomically diverse even, than among whites and other groups, right? So it creates a whole set of issues that come at the level of just like the infrastructure of data collection. And even when you have great data, which we've had access to, there's all manner of layers of bias in there.
Yeah, and a point for the students here that everything that John mentioned, each of those are multiple different problem areas for future research. I'm just trying to figure out what to do about them and how we could overcome these gaps in the data to get better models, and lots of great ideas that could be pursued. Many of them not at all easy, but all interesting.
Yeah, and I think that's another critical, like when we talk about preparedness, right, as a framework, right, it's like when I started out as a grad student, I had this idea that I was going to like write a paper and that paper was going to send shockwaves through the world and change everything. And then I got very sad because I realized that like 10 people read my paper and, and I wasn't really sure what the impact of it was. And then over time, you start to realize that no, we're kind of collectively and imperfectly breaking this thing together, and it takes time and it takes patience. But in order to be prepared for these things, you have to be running that machine for a long time before, right? And hopefully we've got a long time before there's another pandemic. We also have many other infectious and non-communicable diseases that reflect the same kinds of inequalities, right? So, we don't need to wait for the next pandemic to be prepared. But obviously, if there is another calamity on the scale, we want to be better prepared than we were the last time.
Yeah, agreed. Other questions? So I think if nobody else has any further questions, I want to encourage folks to follow the link that just posted and take a look at John's slides, which he's nicely put up for us. And I know I was downloading several of the papers that he mentioned there, and now I've got a few things to add to my reading list. And so you can take a look at those papers and dive right in. And so I'll just say thank you so much, John, for this interesting talk and start to our conference. Really appreciate your time.
Yeah, no, thank you so much for having me. Thanks for the questions, and really don't hesitate to get in touch if you have questions after the fact. So thanks, guys.